the country that are able to share with us their expertise. I think that, like I say, I really hate the term, but that they really are thought leaders in the areas that we want to talk about. And so I'm super excited today because this is like one of the areas that I think everybody at CEG, at Community Education Group, I think they bang their heads up against the wall every time I mention this, right? And that is that I believe that MAT, medically assisted treatment providers, are the hub of where we need to be focusing our attention to address HIV and viral hepatitis, not just in this region of the country, but in the country, period. I believe that there is a central theme throughout many of these providers, and that is that if they screen for HIV, hepatitis C, linked to care, and in the case of hep C, provide treatment and or link to a cure, I think that that might be where a big percentage of that 24% that we keep missing lie. And I think that we've got to figure out how to mobilize them. We've got to figure out how to educate them, but we've got to figure out how to pull them in as a part of our team and our team of response. So I want to introduce some people that I think some of you may know. I'm going to give them, this is how we're going to do this. And everybody who hasn't been here before, Judith, I know you've been here usually as a guest, so you know how crazy this can be. So we're getting ready to rock 'em, sock 'em robots. If you got questions, put them in the chat. If you got questions, raise your hand and use your little hand thing. And so we've got a bunch of people on this call. So again, just put your questions in the chat or raise your hand. I'm going to interrupt everybody anyway, so I'll probably ask your question for you, and that's a goal. The first person I want to introduce, and believe it or not, I want everybody who's ever been on this call before to hear me say, I want to introduce Marie, and she has a video. So I have allowed her to bring slides. Go ahead. Introduce yourself and then play your video.
Okay. So my name is Marie Sutton, and I'm CEO and founder of Imagine Hope Incorporated. We work at this very busy intersection of HIV, hepatitis C, substance use disorder. That's where we live. We started this project in 1996 with our HIV work. And in these past 25 years, we've tested close to 250,000 people for HIV. In 2013, or really earlier than that, we had clients coming to us to say, thanks a lot for the HIV testing, but we're really worried about our hepatitis. So we could see it coming. We knew there was this, sort of perfect storm of medication coming online, rapid testing coming online, and the opioid epidemic all at the same time. So we sought resources to do something about this, and we were uniquely positioned to do it because we had long and strong relationships with 40 substance use disorder clinics in the state of Georgia, 18 of which are MAT programs. So we have built a hepatitis C program. We've screened about 70,000 people. We're in our 9th year, and we've got 650 plus cures. And we built capacity to treat hepatitis C in 5 MAT programs. And I'll say,
Marie, can you go back again? Hang on. I told you it was going to happen. I told you I was going to interrupt you in the middle of a sentence. Can you go back again and say what you said? Because I want to make sure people heard what you said.
Which part?
Went through it. The 650 cures.
Yeah, we've screened 70,000 people. Now we need to cure about 4,000 people, and we're in a non-Medicare expansion state, and all of our clients are uninsured. So there's our challenge. So we think that 600, it's actually 658, I think, as of last week. That's really a big deal to be able to get those folks cured. The other thing that we think is a big deal is that 91 of those were cured in MAT programs where they received MAT services and hepatitis C screening and treatment on site, right there, wrapped around together in tandem. And that's really where that's my dream. My vision is that if you enter substance abuse treatment, disorder treatment anywhere in the state of Georgia, whatever brand you want, you're going to be screened for hepatitis and treated. That's the big dream. And I'm going
to ask you to play your video so we can get an introduction, and then we can start our conversation.
All right, let me see.
We'll get introductions from everybody else, because I see Judith chomping at the bit. I see Stephanie chomping at the bit. I see Todd chomping at the bit. Y'all are bit chompers.
All right. Can you see it all right?
Yep.
Come on. I know I got to do this right since y'all are making a precedence for me to
Yeah,
play.
I mean, and you don't even know. I'm like, if this don't go, you know, well, you know me.
I know. Well, I'm
I'll
gonna
move on.
I'm gonna stand by it.
All right. Uh-oh, no volume, no sound.
We saw it coming, like a storm on the horizon, a silent killer, one that would reach into communities throughout Georgia. Hepatitis C.
I think we've started seeing a lot more heroin use, a lot more IV drug use, so we've started seeing a lot more positive hepatitis C cases. Programs like these are primarily self-pay. So patients that wanted medication-assisted treatment had to pay for it out of pocket, which is very hard.
Yeah, it was rough. It was hard, physically, mentally, emotionally, everything. My main concern was about my child. I didn't have good insurance, and thinking my life is gonna be cut short and I'm gonna miss so much.
It's as deadly as it is curable. We saw it coming, and we were ready. We chose to believe in a brighter future. With partners from Rome in the North Georgia mountains to Brunswick down on the coast, we've built a human bridge, connecting those impacted to care.
Has just gotten so much easier, so we can bring a lot of people into treatment that couldn't access it before.
We chose hope that the opportunity to live a long, healthy life would be available for each of us. Hope that we could turn back the storm through relationships built one at a time. And even though we knew it would be challenging, we did it because it was the right thing to do. And because we knew we could. Isn't that in all of us? That desire to be part of something bigger than ourselves?
With Imagine Hope's help, every person that we've treated here so far has been cured.
This program is amazing, and it literally saved my life. It was just like a dream come true.
Together, we can choose to imagine hope, to imagine a future without hepatitis C, and a future as promising as a Georgia sunrise.
That's good. That's a good launch. Perfect. Thanks so much. And I mean, and I see why you're proud of that. I mean, it literally takes a village in order to kind of get that mobilization and that sort of programming going. So that's perfect. What I want to do next, I want to go to Todd and I want to go to Judith to talk about the project at Yale, because you both are working on that. Do I understand that right? Because, you know, Lee always gives me bad information. So.
No, it's me and Judith.
Okay, you and Judith. All right. I
Yeah.
didn't know who, because, you know, I told you it's Lee's fault. Don't blame me, blame Lee. I always blame somebody else. So why don't you talk to me about the project that you're doing at Yale?
Okay.
Okay, we have a few slides. Do you want?
Oh, no, you don't.
Right.
Come on, Tony.
No, you have one. You got, huh? You get two
Okay.
slides. Two.
Don't even worry about it, Tony. So what Stephanie and I are working on is a grant that we have with collaborators at Yale to integrate care for opioid use disorder, HIV, and hepatitis C in 20 primary care clinics across the state. I think 17 of them are FQHCs and 3 are WVU or CAMC affiliated primary care clinics of family medicine. And it's a 5-year grant. We just started year 3. We have the 20 sites divided into 4 groups of 5. We have just started working with group 2. And what this is about, this implementation science study, is getting, because every clinic is in a different place with regard to screening and offering treatment for these 3 linked entities. We have a highly individualized approach that involves a change team at each site. There'll be a
What
change.
is that? What is a change team?
I'm going to tell you. There's
Okay.
a change leader that gets identified by the administration, and that person pulls in other staff members, and there should be broad representation across administrative stuff, clinical stuff, social work stuff, you know, addiction services. And what we do is we help this change team with guidance and support. We help them address the issues of where they are in this continuum of screening for these three entities so that they get a diagnosis, and then initiating care for these three entities. Now, some places have medication-assisted treatment, Suboxone, built in to their system. Others are still in the state where they're referring out. Others are ready to take it on and start doing that. And so, as I said, it's highly individualized. Every site is unique. And we are, through a coaching process, helping them get this going. And then we get the measurement of their success directly from their EMR. So we pull the data out of their EMR. How many people?
Judith, what's an EMR?
Electronic medical record. So we pull the data from their electronic medical record, see how many patients they've seen, how many they've screened for substance use disorder, how many people have been referred, how many people have a prescription, for example, for buprenorphine or opioid use disorder, and similarly for HIV and hepatitis C. That's the primary goal. The secondary goal is to improve treatment across the board across a series of standard primary care health, health indicators, like, of course, appropriate to age and gender, screening for breast cancer, screening for colon cancer, screening for diabetes, screening for depression, so that we ensure that individuals who of course primarily have opioid use disorder, HIV and or hep C through injection drug use, also receive the full range of appropriate primary care services. So that's the secondary goal of this. And we're happy to answer your questions. We're very excited about this project.
Okay, because my big one before I get to Todd and Alain is, how many people do you think you are going to reach, or what was the goal? What was the goal of the number of providers to reach and the number of individuals?
So the goals are not set by either providers or individuals, that it is set up by primary care clinic. And then, of course, some are very busy and see a lot of patients. Some are smaller and see much fewer. So it's going to be scaled to what each site is capable of doing, is already doing. So I can't give you an exact number.
Okay.
I added a link in the chat for y'all. It's to the NIATEX model, which is the model we're utilizing, as we go into each of these sites and work with our change teams to kind of look at each organization and identify what are the facilitators and what are the barriers to expanding, the screening and treatment for these particular diseases. And the model's actually pretty straightforward. It's kind of an interesting thing. It was developed by the University of Wisconsin, I believe. And it was originally something that was used more in manufacturing, for example, taking a look from the customer perspective, and so we are encouraging these sites to really review what a patient experience is like from the moment they pull into the parking lot until they walk into the waiting room and experience that first, encounter with an administrative person on the other side of a desk, all the way through to the end, so that each site can really think about, other than regulatory things that aren't always in our control, what are some of the other things that are making it difficult for us to offer these services to people, or what is keeping patients from coming to us for these services? You know, like it really allows for a deep dive.
Right. So, Seth, let me ask you one question. And that is, and so in that kind of experience, right, kind of how the patient engages or experiences, is it also environmental factors like the temperature of the building, what the building smells like, are all of those factors kind of being assessed as well?
They're not tested data wise, but they're definitely part of that overall like walk through and evaluating what a patient experience is like. Did they experience a poor attitude from the receptionist at the desk that made them feel some type of way and made them not want to come back? You know, is it a difficult place to get to? Is the parking lot terrible? You know, did they have to wait too long for an appointment, et cetera? You know, just looking at all these things, because, you know, this is multifaceted, as Dr. Feinberg was saying. You know, we have our main goal here of expanding access to care for individuals, but at the same time, it's very helpful if we can look at each individual site and provide some feedback on ways that they could improve the quality of the care that they're giving, reduce wait times for patients and things like that. So, you know, in the end, it can improve a practice while also increasing access.
Right. So Judith and Stephanie, you have a question here. And the question is, any WVU in the Eastern Panhandle clinics a part of this project?
Yes. The Eastern Division in Martinsburg. Their clinic in
There's Martinsburg and Harper's Ferry.
Harper's Ferry. Thank you. I always forget that. I always want to say Valley Forge. I don't know why. Harper's Ferry.
Diana, did that answer your question? Diana Collins, because that's where the question came from. Sorry. Hang on. Sorry. I have a dog that just had staples pulled out for an ACL and the puppy just walked up. Sorry. Sorry. So the next one is my brother from stop, Ralph. Hank, stop. Is my brother from another mother, and that'd be Todd. Todd, you want to tell everybody what you do?
Sure. I'm an addiction researcher at Marshall University. We work on a lot of things. We're running a lot of clinical trials now in various treatments of substance use disorder. We have new treatments for pregnant participants. We're actually about to start a new trial with a new first in line non-opioid treatment for NAS, which would be really cool. But the one I want to talk about is we're also working with Yale, oddly enough, on a protocol where through the NIDA CTN to actually run a clinical trial for office-based methadone. So we'll be comparing office-based methadone versus buprenorphine to get people through their substance use treatment in a the idea is to expand the number of options that MET providers have available to them. Hopefully we can get more people in. That way we can do more wraparound services like HIV, Hep C testing, and additional overall family medicine approaches.
So Todd, can you talk about your work that you're doing with community health workers and that sort of thing? Because I know it wasn't just the application we did, but you're doing other work to engage community health workers. And
well, yeah, there's what we're trying to do is build a better rural research network, right? So we have a number of clinics out in rural areas. I'm a big advocate of having clinical trials and really hardcore clinical research into the rural areas. It increases it improves the clinic. There's a lot of really good literature showing that operating clinical trials, doing clinical research, actually improves the outcomes in your regular clinics. But we're also being able to provide more advanced care options into these areas. So one of the things that we do is we work with some of the clinics in Southern West Virginia, and some of them aren't ours, most of them aren't ours, just sort of collaborations with places like OVP or places like
what's OVP? What's OVP?
OVP is Ohio Valley Physicians. They have a number of rural sites in Southern West Virginia and in Eastern Kentucky and in the Appalachian areas of Ohio. They're they're a private group, but we're able to go in and do some research. Some of the moms in our buprenorphine study came from there. The idea is we're trying to put highly trained, very functional clinical coordinators, in some of these rural areas, so we can run higher end studies. So we can do things that are, we're not just the studies where we're able to go in and collect a few things, but where we can actually get interventional studies and provide more advanced care options in some of these rural areas are really it's important. It's important for, right now you look at it, where do you go? Where are the most advanced levels of care? They're in the urban areas. They're in the areas with that have high access. But if we can move that into poor access areas, if we can move that more into lower resource areas, then we advance the level of care in those areas at a much more accelerated rate.
I mean, and I guess this is a question for you, maybe you, Judith and Stephanie, before I get to Alan, or anybody can jump in and answer this. Would you say, if I said to you, West Virginia or the Panhandle or Appalachia is a naive research study region, would you say, yes, that's true? Or would you say, no, that's not true, and it's just that we don't report back?
I mean, we do a fair amount of research. WVU obviously does a lot of clinical research. Even the School of Osteopathic Medicine does some. CMC does quite a bit. But it's not so much that we're research naive. I don't think we are. I don't think we have integrated research into our clinical practices across the state of West Virginia as well as other states have. And I think that hinders us in terms of the quality of care we're able to provide. It hinders us in terms of the advancements in care we're able to get out to everybody. But the bigger issue is we have areas of huge health disparities. And so I think we have populations that have not been.
And what would, and Todd, what are those disparities? Is it economic? Is it? Well, yeah.
I mean, so if you look at, we've been doing a lot with all the trauma linked, economic linked diseases, right? Substance use disorder, diabetes, obesity, hypertension, high rates of infectious disease, high rates of suicide. All of those disease states are at really high levels in West Virginia. And so you have an area where if we can get better here at finding some of the root cause, if we can get better here at finding measures to show, okay, how are we actually succeeding in helping patients, infectious disease, we know the measures are, right? You're getting it, you're curing it or you're not curing it, you're lowering titers or you're not. But how do we integrate then the social, all these social determinants that create factors that are creating the next generation? How do we build that prevention model in that allows us, how do we measure things before we get increased rates of infection? And that's the area that I think we really need to focus on. And we can't do that unless we're really investigating at a higher level out in the areas, out in the low resource areas.
Got it. Thanks, Todd. I'm actually paying attention. This is the baby that was causing the other one to bark out of his mind. So Alan, last but not least, let's go with you. And Stephanie, I'm going to come right back to you after I let Alan do his intro.
Right on.
Hey, it's good to see everyone. Thanks for having me. This is a great group. I'm an addiction medicine doc, internist as well, and worked for over 20 years doing hepatitis C care. Probably the first 17 years of my career did it in New York City, where we had Medicaid expansion and led integration of Hep C care within a network of methadone programs. So 12 methadone programs, treated thousands of patients over the years, all the way from the interferon era, even, when they were using thrice weekly interferon, even daily interferon, all the way through telaprevir, boceprevir, and obviously now. And then the last 6 years have had a wonderful journey in a non-Medicaid expansion state, working in rural and urban South Carolina, where we've integrated HIV care, prevention, and Hep C care in a variety of settings, from certain service programs to primary care, family medicine, internal medicine, mobile health units that have worked with lots of different areas, like where we do testing, rapid testing, methadone programs, food pantries, homeless programs, jails, emergency departments, hospitals, clinics that serve pregnant women. And then Judith and I have been working on the Corey funded study that's across the country, situated in both primary care clinics and methadone programs, 23 different programs across the country, with a randomized control trial called the HERO study, where we randomize individuals who are actively injecting drugs to a model of either patient navigation or directly observed treatment. So that study is, and also looked at rates of reinfection. So going to stop there.
Well, that was a lot. You don't need to stop there. How many people are in that? How many people are in that study?
Yeah, the HERO study, so that was published in Lancet Gastroenterology, the primary outcome paper. We enrolled 754 individuals, 623 or so initiated treatment, and in an intent to treat, we had about a 73% cure rate. If you included only a lot of people were lost to follow-up. So if we include only the people that actually had a Hep C viral load ascertainment, it was about a 92% follow-up. We found no difference between the two arms of patient navigation, directly observed therapy. We also found some very intriguing adherence data, because we measured adherence with electronic blister packs. So kind of like the,
okay, so Alan, you just did something. So, okay, that was a lot. All right. So, all right. Randomized trial. What does that even mean? Because like there's some people on here.
Oh yeah, sure. Yeah.
What's a randomized trial? What's it? We're going to talk about.
Yeah, it means that we enroll people that were eligible for the trial. These are people actively injecting drugs, and basically flip a coin. And if it's heads, you get one, model of care, which is a navigator, someone to help you through kind of understanding what the hepatitis C is and getting to treatment visits and, motivating you to take your meds. And the other arm, if you get tails, then you get directly observed therapy, which means in methadone programs, for those who are familiar, you walk up to a window, take your methadone. It's kind of only natural to pair that with other meds. So instead of just your methadone, you also get your Epclusa, so your single tablet a day for 12 weeks, or Mavorite. And then in the primary care, because people don't go to primary care all the time, we have to leverage a phone app, phone application from Emoca, which is a vendor, which is kind of a video. You take a picture of, video of yourself taking the medicine and so forth. So that's all it is. It's just flipping a coin to see which arm you get. We wanted to see if one model was better than other. It seems like they're equivalent, essentially. We did, and then after people achieved SVR, and we documented that. And
SVR, what's that?
Yeah, thank you. A cure, sustained virological response, or cure. Beautiful thing about Hep C is that you can actually cure it, which is amazing. That's why people get the wonderful video we saw. Incredible, people. It's transformational because of the aspects of cure. We can't cure much in life, but you can cure hepatitis C. And so, but then people are still continuing to engage in high risk behaviors, such as sharing needles and syringes, cookers, cotton, rinse water, and so they are at risk for reinfection. So we actually followed people for 3 years after they achieved cure, and about 11 out of 100 people every year did get reinfected, and so that was one thing that we did determine. Most people didn't, but certainly it is a risk, and we looked at some characteristics that were associated with that, including homelessness and using methamphetamine, and a number of other younger people, were more at risk than older people. One thing that I was mentioning with the adherence is that, unlike HIV or TB, where you need to take most of your meds to have success and have a viral load that's undetectable, with hepatitis C, we found that it's actually quite forgiving. We obviously strive for perfection, but the reality is, even if you take 50% of your meds, you had a pretty good rate of success of cure. So it's a very potent medication that's forgiving. Important to continue, even if you're taking every other day, to continue through and try to finish your treatment, because those who finish the 12 weeks of treatment were much more likely. They were like 9 times more likely to achieve cure than those who did not complete treatment. So persistence is important more than adherence when it comes to hepatitis C treatment.
Perfect. Thanks. So, Kelly, thank you for putting the Lancet article that Alan mentioned in the chat. If anybody wants to take a look at that, that article is there. The link is there. Thanks again, Team CEG. So Stephanie, you had a question and then I have a question, or you had something, a comment, I don't know.
Yeah, I was just really going to speak to what Todd was saying about, thinking in terms of these rural pockets and how do we address social determinants of health and all of these things. And it immediately got me thinking, about prior work I've done and whatnot, because I'm located in Western Maryland. I have multiple projects going on in addition to my role with the WVU BIRCH project. And I think BIRCH is like an awesome example of ways that we can get in there and help, providers really take a look at what they're offering and expand those services. Now, prior, I had led a study back in 2018, 2019 for Hopkins. And what we were doing in Western Maryland with that project is we were taking an existing model from Baltimore and trying to adapt it to the rural area. And basically what it all boiled down to is we were trying to capture and characterize the lived experience of people who were still in active IV drug use, people who were experiencing, housing challenges and all sorts of things. And I mean, we were boots to ground, we were out there sitting down with folks and really just trying to spend hours with them and learn about their experiences with stigma, with local providers and transportation and all of those sorts of things. And what's funny about it, and that's why I wanted to bring it up for Todd, is here we are, it's 2023, and Allegheny County, Maryland, is still looking to that study as well as the SEED study to inform what we're doing. So I think if we can do more and more of these boots to grounds projects in communities where we are capturing the voices of the people who need the services, truly capturing it, not just here's a survey, check a couple boxes, like I'm talking, qualitative interviews, really sit down and get to the bottom of what they're experiencing and capture that. I think it will help us get a better beat on how to direct these services.
Right.
Well, I think it's more than that. I think we really have to change the way we look at the clinic, change the way we look at research, so it becomes a standard part of practice.
Oh, I agree with that. Yes.
Right. So, all right. So I think I have like some of what I would call the greatest minds in this area on this call right now. So I'm going to ask the question that I've wanted to ask. How do we mobilize MAT providers to be a part of the continuum of care, to whether that's to screen for HIV and then link to care for HIV, to screen for Hep C and to link to treatment and subsequently cure? Because there's not like a national MAT provider group. There's not like a regional MAT provider group, or is there? And we've just missed the boat. So help me.
There is a national group.
Okay, who are they?
It's Todd. Alan, you know who they are. What's it?
Yeah, you're correct. Todd, American Association for the Treatment of Opioid Dependence. It's not, many clinics are owned by individuals or some networks, but it's the overall trade organization, a great organization, Todd.
Yeah, we have a local chapter of that here. Would you repeat your question, Tony?
I mean, I think the question is, what do we do to mobilize them to be more engaged in providing or ensuring that their members are actually screening for HIV, screening for Hep C, linking to care and linking to treatment? For example, in West Virginia, the statute reads that MAT providers are not supposed to let people opt out. That if you read the whole statute, they're supposed to screen for HIV and Hep C, but many providers that we've spoken to believe that they have an opt-out provision. Like, we don't want to ask about, if they say they don't want HIV tests, we say okay. If you don't want Hep C tests, we say okay. What is it that we need to do? What is it that we can do? Is it with an ATOD, or is it we're going to have to go clinic to clinic to clinic to clinic? Because Lee's gonna be tired knocking on all those clinic doors.
So I think a key thing, Tony, is to get primary care providers, whether they're in a clinic setting or a private practice setting, to get their IT person to help them structure their electronic medical record so that these key screening tests, screening and diagnostic tests, can be ordered. So when I say this, I'm talking about screening for HIV and hepatitis B and C can be ordered with a single click. And these should be considered opt-out. In other words, the stance of the provider should be, these are tests I order for every person I take care of. And then if the individual does not want to be tested for HIV or hepatitis B or hepatitis C, for example, they can opt out. But mostly this is the way, most people do not opt out, and this is the way to provide appropriate screening and diagnosis in communities like West Virginia and the rest of Appalachia, where these diseases are rampant because of injection drug use. For substance use disorder, we share with the sites that we're working with at BIRCH a single item question, because a lot of clinics use more complex ways of going about. Do you drink too much? Do you do this? Do you do that? Do you do the other? So, we've got a single question, and then there can be follow-up to that. And I think the more we share this guidance with primary care providers, the more we will have people who are screened and diagnosed and then hopefully treated appropriately. If we don't do that, then we're still going to be experiencing people who show up with advanced disease or people who die of an overdose, whatever, before the healthcare system can offer them anything.
Right. So hang on, Judith, we got a note here. It says, Judith, that's a great plan. Though in NYS, if I wish I should have brought my reading glasses outside, that is the law, and it's still, and we still have a lot of folks who just click it off in the EMR rather than to talk about it.
So I don't disagree. Listen, I started my research career in HIV. That epidemic is 40 years old. We've had a screening test since 1984, 85. And I still give grand rounds and ask people in the audience who are like internists or family docs, do you screen everybody on an opt-out basis for HIV, which is the federal public health service recommendation. And the number of hands that goes up is frighteningly small. So it turns out that doctors are stupid people. In many regards, they're stubborn. They're creatures of habit. Getting them to change their habits is not easy. And we have to just keep pumping away at it. I will say that, for example, nurse practitioners and PAs who are also primary care providers, physician assistants, are much better, much better than physicians at acquiring new skills and implementing them. So to the extent that we have advanced practice providers, which is the umbrella term for nurse practitioners and physician assistants, the better off we'll be, because they do a better job of screening for diseases than docs do.
So I guess maybe let me ask the question in a different way, because you're talking about this from a physician point of view. And we know that many MAT providers are small, more, rather than being doctors, were therapists and had a therapeutic practice that turned into an MAT practice for a different, for a myriad of reasons, need, demand, the dearth of opportunity, particularly in rural communities for providers. So they met this need. How do we bring them into this fold too? Alain, it sounds like you and Marie kind of know about this, have more information on this ATOD group. How do we kind of get those, that are not necessarily medical providers, but maybe
Yeah, no, this is it's a great question. I mean, this is something I've struggled with my whole career is how to initially, because New York has a lot of advantages, New York City, and we were integrated with a, academic medical setting, had a lot of grants. It was, it's hard, but it's somewhat easy to do, relatively speaking, and so as I've kind of gone out to other areas, it is really difficult. I've had more, the studies show, like there's a 2013 JAMA study which showed that, look, public programs are much more likely to test than nonprofit, more likely to test than private, right? And there's a more recent study which showed only half, I think it was in JAMA again last year, only half of the methadone programs are testing for HIV and Hep C. It is hard because, a lot of these privately owned methadone are providing a real service. They are providing a life-saving medication, and they don't have much medical care at all. They might have the minimum that comes through. So I don't really see it as, I would hope that the White House elimination plan would build within provisions that it's not just about giving away meds. We need to provide, like a Ryan White program. We need to have a delivery system for healthcare for people that inject drugs, for people with opioid use disorder. Otherwise, we're not going to get this right. We've done things because we know that it's not realistic. I'm very inspired by what Marie has done, and so it is possible to do, and it is certainly possible. But if you're talking about every methadone program, sometimes we got to do different models, right? One size will not fit all. So we come up with the mobile unit. We know that this program is not going to do it themselves, but people want the care. We come in there, maybe it's twice a month. You test people and you treat them, and people want that. That's a model. Andy Talal has done a model of telemedicine. You still need to have somebody there to kind of help navigate through it. And these were still some programs that had some resources in New York State, but you can have a treater, whoever it might be, somewhere else and provide treatment. But it does require some infrastructure and then some financing, right? You got to be able to integrate. What we did at Albert Einstein, we integrated, we had a billing system, we were able to get some revenue from this, but that takes a lot of team members and support. And so I think, honestly, there needs to be resources and there needs to be, funding mechanisms so that every methadone program in the country, if we're talking about $5 billion plan, they're going to have the infrastructure, whether it's some like OVP coming in there, some group coming in there to do it, or building their own because they have a nurse practitioner or a physician assistant. I agree with what Judith was saying, that this is going to be the workforce. That was what allowed us to be effective, was physician assistants in New York and nurse practitioners in South Carolina. So I think we have the models, but it's not, I've been, disappointed that I thought over 20 years, this would be a lot better. Honestly, it's not at all, right? There's more inspirational points like Marie's, programs, and lots of different Judiths doing amazing work. But overall, majority of people that are in methadone are still stuck without treatment for something that's totally curable. That's something probably should be over the counter, no side effects, it's just something that, people should just get their 90 pills sent to them in their house and just start taking them, right? It's just something so simple now. And so, I'm going to stop there, but I do think there's ways to do it, but we need to put a lot of funding into the delivery systems. Meanwhile, we should still try to do the things that we're all doing, to try to pick off the 1,000 points of light, or, the George Bush thing, which I never understood until now, the 1,000 points of light, Yeah.
But I'm sorry, Marie, did you have something to add here? Or
I do.
Okay, go ahead.
Well, we've had some success in Georgia, and all of the things that you all have said are true. Yes, we need the big system of care. We don't have a robust system of care. But if we hadn't done anything, those 650 people would still have hepatitis C, and they probably would have infected 20 people apiece. So we think we're eliminating hepatitis C in Georgia by the work that we're doing. And the way that we approached it is we went to the clinics we already had relationships with. This is all about relationships. And I don't mean relationship with the clinic. I mean a relationship with one internal champion who will drive this bus. And that's what we need. We need these relationships. All the systems and the electronic medical records they're fancy and they're fun, but I need somebody who's going to lock arms with me and get this job done, and somebody who really wants to do it. And so we have this collaboration of about 40 clinics, 18 MATs, a syringe exchange program, 2 drug courts, some traditional quote abstinence-based programs. And we've got a champion in every single one of them who drives this. And when we went to them, because they're the same champions that do our HIV work in partnership with us, we said, what's the barrier? Do you want, they say, this individual person that just drives back and forth to work, that doesn't maybe even have anything to do with the running of the clinic, says, I want to do it, but the clients don't have the money, they're uninsured. And even if it's $12 for the or $9. They don't have it. Are they going to get an antibody test for $9? Or are they going to get their dose for $12? They're going to get their dose. So we come in and we pay for all the diagnostics. That's the barrier to care. We can get medicine through patient assistance programs. It's the diagnostics that really are troublesome. So we have Quest diagnostic counts all over the state of Georgia, and we secured funding to pay for that. That removes the barrier. So standard of care, anybody who gets a blood draw in any of our partner clinics gets screened for hepatitis C. It reflexes to the RNA, to see if they're chronically infected. And then that reflexes to a hepatitis B. So we got that panel done. Then we pick up basic chemistries. They're good to go. So if we refer them, we have some telemedicine portals and some FQHC type places. Then they come in with the whole package, and our navigators work to help people be ready for care. So we just built this ourselves by solving one tiny problem at a time. Not a big problem, but one little problem, and then the next little problem. And they're all kind of different. They're mostly rural. We've got navigators embedded in these rural communities that walk people through. Some of our clients, it has taken 6 years for them to get a cure. Some of them get cured in 6 weeks because they could come in fast. But it's all about the relationships with the clients, the relationships with the clinics, and the relationships with the funders.
So I agree with Marie that I think it's really important to have a champion. We have a program here in West Virginia. We have the virtue, of course, of being part of the Medicaid expansion from the beginning. So people can, in fact, get Medicaid insurance. But we have a program where we teach primary care and addiction care providers how to cure hepatitis C.
We do too.
And in 3 years, we have received over 1,000 consultations. Our cure rate is 99%. 22% of the providers are people who write prescriptions for buprenorphine. So they provide MAT. So that's a little over a fifth of the primary care pool. And, they become known not only inside their institution, but in their community as somebody who knows how to do Hep C. And then they accrue other referrals as a result from either from syringe exchange, from self-referrals, from within their own healthcare system, from providers outside their healthcare system that aren't ready to do Hep C. And so it's really a matter of getting that person in a situation started and supported. And we've done so well with Hep C. We just started a parallel program for HIV.
Well, we found that people are really that the mid-levels, are nurse practitioners mostly, and it really is what I am working with is a team of rural nurses that I'm telling you what, these men and women, if you're in trouble, if there's a hurricane down in South Georgia, these are the people you want. These are the people that can get it done. And they're the ones that are really pushing this, but they want to do it. When somebody gets to say you're cured, we're working with a population that's a lot of chronic issues, but this one, it's like being Santa Claus. I mean, people, once they get a hold of it, they love doing this. This is just so good. So we have an ECHO program here with Department of Public Health and Dr. Leslie Miller with
Marie, can you just for folks who don't know what ECHO is? I know Judith has done some ECHO work, and I know you're doing ECHO work. Can you tell people what ECHO is?
Yeah, this is we modeled it after a program in Washington State, and so we've got Dr. Leslie Miller and Dr. Fugner and Dr. Felzine and Brian Perlman who come on, and then we bring we're their primary customer. We bring our cases, our complex cases. Most of our cases are pretty simple, and then they teach. So when we go in and provide classes to build capacity to treat for providers who are primarily doing this methadone work, we want to have support for them so they can come and we are first Thursday at noon. We all gather together. We present cases and we look at the complexities of this. So people aren't just, okay, here's your go forth and treat, but you've got some backup and some support. So we have 5 MAT programs treating that came under this ECHO project, and that's where the 91 of those cures came from that project. And it's small, but I tell you what, we ring a bell every time we get a cure. That bell is just ringing, and we're just building this ourselves. And when the big, Biden 5 million comes, we will be poised and ready. Because I'm not just going to sit around and say, well, I wish the feds would do something. No, I know how to do stuff. We know how to do stuff. And we're really doing it here in Georgia. And we have a long, long way to go, but it is doable.
Yeah. So, we're about 5 minutes out. And so I want to say a couple of things. One is that, I'm going to give you a last round, 1 minute or less question is the role of politics in us getting this done. And what do I mean by that? I mean, yes, there is a goal for a Hep C elimination plan. I think that we have to see what happens funding wise from the feds with the rescission that's happening in Congress. And so I think it may impact what resources go into hepatitis C. I think we look at West Virginia, where there's an opioid treatment moratorium, where we only have 9 methadone programs in the state. That's problematic. When I think about the work Todd's doing and the work that we're doing in training community health workers throughout the state, how do we make sure that we're getting the same providers to recruit and retain and hire these people, and make sure that we have a balanced understanding of them as valuable employees, that they can have value to many of these clinics. So in our 5 minutes, we've got 1 minute per person, role of politics or whatever you want people to know as we close out. And I'm going to go in the reverse order that I did. So Alan, I'm going to start with you.
Yeah, no, I agree with what Marie, Judith, others are saying, that we don't need to wait, for some savior to come in. We can do it. We've been doing it, and there's a roadmap and ways to do it, and we're willing to share, all of us, our collective experiences and learnings. I think trust is an issue. I think there's methadone programs out of the ones that we saw in the video. I'd like to think some of the ones we had in New York City, where there was a really, for many, deep trust between clinicians, other patients, and providers. But there's, a whole kind of history around methadone. And so in my travelings and talking to Todd and so forth, a lot of methadone programs say we've done it and we can't get anyone to come. And so one solution for that is to really work with peers, work with your patients, so you get that first cure. But it's going to take a different way of being collaborative and working with your patients to figure out solutions. I suspect that any of the successful programs are doing that, either formally or informally, but it is something that I've heard, that because not everyone, for many clients or patients, they come into the methadone for their methadone. That's it. They're not going to want anything else. They're not going to trust to get healthcare there. And so how can we kind of overcome that? And that's really going to be through peers and peer educators and building that relationship. So I'm going to stop there. Thank you.
Perfect. Thank you. Thank you for joining us. Thank you so much, Alan, for giving us time. Todd, are you still there?
Todd dropped us a note. His devices died, so
Okay.
He sends his best regards, but won't be back on.
Okay, perfect. Thanks. Stephanie.
I think the biggest thing is get people out of silos. I totally agree with what Marie was saying. It's all about those relationships, and I'm big on making noise. I tell people here in Allegheny County, if you build that recovery community and people are loud and proud and you're having events and it's in people's faces, it becomes a lot more challenging for political leaders and other officials to kind of, pretend like it's not happening.
Perfect. Thanks. And thank you so much for your work. And thank you for joining us and giving us your hour today. I really do appreciate it.
Thanks
Judith.
so much for inviting us, Tony.
Judith.
Well, I think we need to keep pounding on the door of our legislators in West Virginia. We're incredibly hampered by rules and regulations that our legislature has saddled us with. It really has very deleterious effects on providing harm reduction and being able to really mobilize to take care of the community of people who use substances. And We haven't been very successful recently, but I think we have to keep trying. Because, you know, right, you said there's only 9 methadone clinics in West Virginia. Well, there's a moratorium on new ones, and the legislature holds the key to that. And not everybody thrives on buprenorphine. We need alternatives. I mean, you think about, you have probably 30 medicines choices for hypertension. We have 2 decent choices for opioid use disorder, right? Buprenorphine and methadone. That's not a lot, you know, and so we really need to be able to offer people what they'll thrive on.
I think, you know, and I think that the other thing is that we have to be, I think that's why I asked the political question, because in the Appalachia region, you know, many people still believe that the best solution is an abstinence-based model.
In fact, I was on a conference call with the board of an FQHC that's part of our BIRCH study, and somebody on that board who's also a county commissioner in that county said exactly that. The only thing and he's a lawyer, the only thing I believe in is abstinence.
I know there's also a lot of problems with incarceration being viewed as like the only way out, like just throw them all in jail and that's going to magically fix it, because, you know, there's a lack of knowledge about incarceration as its own sort of social determinant of health, you know?
Perfect. Thanks. Last but not
I think you're calling on me, Tony.
least, and thank you so much for joining. And I'm so happy that you took time to join us today. Yeah, I am. I am.
I'm really happy that
It's your turn.
I'm happy that I came as well, and I'm really glad to be part of this. I try to change hearts, not minds, because that's the way. That's just our method, our model. And I have close relationships, or as close as I can get, to anybody medical in the Georgia Assembly. Health and Human Services Committee is well aware of our work. They support us modestly, and I never miss an opportunity to tell them what their dollars have done. You know, I want them to know it's their cousin, their grandmother, their auntie, you know, that these are not those people. The other thing that really helps us here in Georgia is we have a very strong advocacy group around recovery, and huge support there in our very conservative state. So that helps us. But I just do it by making friends. Honestly, that's the secret.
All right. Thank you all so much. Alan has put in the chat that he's got a PCORI study, and that's big money. That's like so much money. He's going to need a wheelbarrow to get that study. When that study gets funded, he's just going to be like at the downloads with a little wheelbarrow. So if anybody's interested in working with him, or has kind of the things that he may be looking for partnerships, I think that's a very good opportunity. I know that Todd's doing a lot of work around community health workers. So if there's folks that are looking for that kind of opportunity, reach out to him. I think that if people want to talk to Marie about replication of what they're doing in Georgia, looks like it's going great. I think you should reach out to her directly. All of the things that were in the chat, any sort of slide or link, will be going out to everybody. Stephanie has put a ton of stuff in the chat. We'll make sure that all of that information gets out to you. I want to say thank you all for who joined us, and all who stayed with us for the entire hour. And the people that didn't, we don't like them anyway. All right. Have a great day, everybody, and have an amazing week. It's a beautiful day. Get outside for at least 10 minutes. See y'all later. Thank you, everybody.